Welcome. You are listening to MTR webinar number 2, discussing critical appraisal and interpretation of systematic reviews and meta-analysis. My name is Barbara van der Meij and I am working as a conjoint senior research dietitian at Bond University and Mater Health Services. A practical note, it is helpful to have a copy of the sample paper of L. Hamden while attending this webinar. And there is an option to pause halfway the presentation and to practice with the appraisal questions. The aim is that after this teaching session, you will have a better understanding of how to read and appraise systematic reviews and meta-analysis, and how to interpret findings and the relevance of systematic reviews. These skills will be useful for your own evidence-based practice. The next 2 slides just briefly describe the definitions of a systematic review and a meta-analysis. In a systematic review, one first formulates a question and then uses systematic and explicit methods to identify research on this topic. This also includes critical appraisal. A meta-analysis can be a second part of a systematic review. It combines all the results of the retrieved studies in a quantitative way and gives a single estimate of effectiveness. So instead of multiple different results from multiple studies, meta-analysis produces a single estimate of effectiveness, the so-called pooled estimate. However, this is only possible for quantitative outcome variables that have been assessed in a comparable way. So for instance, when multiple studies have investigated the effect of a certain intervention on body weight. The pooled estimate would be the average effect on body weight of all the studies combined. As you can see in this table, a systematic review has the highest level of evidence, as high as a well-designed and large experimental study with a narrow confidence interval. This means that when a relationship has been proven in a systematic review, the evidence for this relationship is quite strong, and it is stronger than positive effects obtained by only one small study. Our evidence-based practice is based on results of systematic reviews. So for that reason, we want to be sure that the systematic review has been well conducted. Poorly conducted systematic reviews give misleading findings, they are detrimental for clinical practice, and potentially increase costs without giving any benefits. And that's why critical appraisal is essential. I thought it would be interesting to use a systematic review on a relevant topic in our field as an example today. This review investigates which is the most effective way to lose weight: alternate day fasting versus daily energy restriction diets. Alternate day fasting means there is a fasting day during which 25% of the dieter's estimated energy needs are consumed, typically around 800 kcal, followed by a normal feeding day with ad libitum food and liquid consumption. This review was conducted by people from the Johns Hopkins Bloomberg School of Medical Health in the US and published in an open access journal of which the impact factor is unknown. So I chose the CASP checklist to critically appraise the systematic review. CASP has several critical appraisal tools on their website, also for randomized controlled trials on quantitative research. You can use the link displayed on the slide. Today, the CASP checklist for systematic reviews will be discussed, and it includes 10 questions divided into 3 sections, A, B, and C. This slide just gives an overview of all the questions of the CASP checklist for critical reviews. Section A looks at the validity of the results, the quality of the study, and the risk of bias. First, there are two screening questions. If you answer both questions with a no, it might not be worthwhile to continue reviewing this paper. A systematic review should address a clearly focused research question and should select the right type of papers. Those are the two first questions. The following questions of Section A check for relevance and quality of included studies and whether combining results was reasonable. Then Section B and C focus on the overall results and the precision of the results, and if the results can be applied in clinical practice. So, starting with Section A, the first question looks at the research question of the review and whether this question is clearly focused and specific. In other words, are the population studied, the intervention, and the outcome parameters specified in the review question? The second question is whether the authors looked for the right type of papers. Do the retrieved papers relate to the review question, so that the included studies can provide the evidence needed? Also, do the studies have the appropriate study design, preferable randomized controlled trials? After having answered the first two questions, you need to decide if it's worth continuing appraising this paper. We will have a look at the sample paper of Alhamden now. So the review of Alhamden addressed an aim, which was described at the end of the introduction on page 294 and is displayed on this slide. So instead of a question, they described an aim, and the aim did not specify the population of interest, as we can see in the text. It could well be the overweight and obese population, which was described in the introduction, but we are not sure yet. The type of interventions are the two diets, alternate day fasting and very low calorie diets. And the type of outcomes are weight, fat mass, and fat-free mass. The comparison for the outcome variables is being made between the two diets. So as you can see on the slide, all required items of the aim have been ticked except for the description of the population. So the second question, did the authors look for the right type of papers? And you can find the answer again on page 294, Study Selection and Criteria. The exclusion and exclusion criteria were applied. There were no case studies or animal studies or studies older than 15 years included, and the inclusion criteria specify the age and BMI range and give us more information about the studied population, because you can see BMI greater than 25 was within the selection criteria. Also, the duration of intervention was specified between 3 and 12 weeks. And the authors also gave an example of their literature search command, which is not displayed on this slide. But when being critical, I noticed that the criteria do not specify the characteristics of the alternate day fasting studies, only those of the very low calorie diets. So in that sense, the selection criteria were not 100% accurate. So after having addressed the two screening questions, we need to decide if it is worth continuing. The aim was described, but we missed a detail on the population, but this we found back in the inclusion criteria, a BMI greater than 25. We also missed a detail on the alternate day fasting diets, so this could be regarded as a borderline quality systematic review. The two screening questions were not fully answered with a yes. Despite this, I will give it a go and will critically appraise the paper today. And therefore, we continue with question 3, 4 and 5 of section A. Question number 3 is about including the most important studies. Did the authors thoroughly search for studies? A good review will have tried to find all the research on the topic. So that means it is better to use several databases instead of one, and in addition to retrieve studies from reference lists, studies written in other languages or new data published on conferences. And for transparency, it is better if the authors include a list of search terms. And the time frame of included studies is also relevant. For instance, was it a selection of the last 10 years? Question 4 covers the quality assessment of included studies. This should be described to ensure that only valid and reliable evidence went into the review. In this step, you need to search whether quality assessment has been done and whether the tool was attached or referenced in the paper. Okay, so the next question refers to the meta-analysis in the review. If results are pulled together by meta-analysis, the studies need to have done similar interventions on similar populations, and they should have measured the same outcome in the same way. In this step, you could also search for details on how many reviewers have extracted data from each study. For instance, it's better if 2 people have done that than when one person has done that. And also whether double entry of data extracted from the studies has been done. These measures would minimize error. You could pause and address question 3, 4 and 5 now for these. We will now continue with the answers to question 3, 4 and 5 of the L. Hamden paper. Were all the important studies included in the sample review? I don't think so, because in the methods at page 294, you can see that only PubMed was used to retrieve studies. No other databases, reference lists, or conference abstracts were searched for. Question 4 on quality assessment would be answered with a yes. The authors documented an instrument that was used for quality assessment, the Downs and Black quality checklist. The next question asks, was it reasonable to combine results? And when looking at table 2a, it was. You can see that every study included in the meta-analysis reported a change in body weight, fat mass and fat-free mass. And the studies had a comparable amount of females. Actually, the majority of the subjects were female. A summary for the second part of section A. Probably not all important and relevant studies were included in the review, because the search was only done in PubMed. The quality assessment and the combining of the results was well documented and seemed to be fine. Section B is about the results of the review and the meta-analysis. You will need to review the results section of the paper and look at the meta-analysis and results of other studies. How meaningful are these results? Is the intervention effective in all instances, or only in terms of some outcomes or some populations? An important item is the precision of the results here. You need to look at confidence intervals for this. A confidence interval is a range of results between which the true answer lies. So the greater the difference between the two numbers in the confidence interval, the greater the uncertainty about the results. The true results could actually lie at either extreme of the confidence interval, the lower and the higher one. Would you still be happy to use the intervention if that was the case? Each analysis will have its own answer for this. This This slide shows the forest plot depicting the confidence intervals of studies included in the meta-analysis of fat mass of the Alhamden study. I took the fat mass forest plot. There were also forest plots on body weight and fat-free mass. You see here the alternate day fasting studies depicted first. 5 studies have been included in the meta-analysis. Below those, you see 7 studies on very low calorie diets. The line in the middle is the line of no effects. Then you see the average effect for each study, including the confidence intervals, printing on the right-hand side of each single study. I highlighted the study with the smallest reduction in fat mass after the intervention. The last column gives the percentage weight, which just means the percentage of subjects in the individual study as a percent of the total subjects from the 5 studies on alternate day fasting. The pooled change is what we are interested in. This is the combined effect size from all 5 studies on alternate day fasting. And you can see that the mean reduction in fat mass is 4.06 kilograms and the interval lies between 2.99 and 5.30. For the low-calorie diets, very low-calorie diet studies, the pooled effect is slightly higher, 4.22 kilograms of fat mass loss, and the confidence interval is a little more narrow, between 3.95 and 4.5 kilograms. It's interesting to see here that all the lines are really on the right-hand side of the no effect line. Sometimes in other studies, other systematic reviews, you will see that the lines also cross the no effect line. Here it's quite clear that all studies had an effect on fat mass. The Section B questions and answers for the sample review include: the overall results were that there was a difference for weight, fat mass and fat-free mass for both studies, but alternate day fasting also had a relative preservation of fat-free mass, which is beneficial. So the precision of the results was moderate. When looking at the fat mass results, for instance, the range within the confidence interval limits was about 2 kilograms. So the results could be anywhere between 3 and 5 kilograms of weight loss. It could have been worse though. Sometimes you see meta-analysis with a confidence interval between, for instance, 1 and 6 kilograms or even larger intervals. We saw in the forest plot that all pooled estimates were on the right-hand side of the no effect line, which is also a good sign of a consistent effect on fat mass. Section C is really about the relevance of the results. Are the results clinically meaningful and can we apply them to the local population? Then next, question 9, are the outcomes discussed the most important ones, or do we need other information, for instance, other outcomes or other populations? And then finally, are the benefits worth the harms and the costs? In other words, is there only a small change but the costs are high? Will the change be worth all the expenses? Or maybe there are adverse effects. Is it then worth to do the intervention? If we look at our sample review, I would say that the population is not very specific. Does this review really tell us that for anyone older than 18 years with a BMI greater than 25, alternate day fasting is more effective and has a better fat-free mass preservation than a very low-calorie diet? I would be interested in gender and selection of diabetes patients, specific age groups, for instance. So To my opinion, this review just gives a rough idea about the efficacy of both diets, but the results cannot be applied to the general population or subgroups as yet. The outcomes were certainly of interest, but the long-term effects of the diets are also relevant. Did the subjects regain the amount of body weight and fat mass in the months following the study? Also, the authors did not comment on cost effectiveness and adverse effects of the interventions. So there are still many questions left. Having said that, you can see here the conclusion of the authors. The conclusion addresses the original question about the difference in efficacy between alternate day fasting and very low calorie diets for weight loss. And the data showed that alternate day fasting is efficacious for individuals with obesity. It's interesting that they do not mention overweight here, but specify obesity. I don't understand that. They also state that this information is relevant to healthcare providers and obese individuals, but unfortunately, the authors do not give specific directions for future research. In conclusion, the sample review is a nice example of a systematic review. When addressing the critical appraisal questions, I found several issues of concern and therefore might not base my clinical practice only on this review. So what have we learned today? Not every published review is of good quality, and critical appraisal is time-consuming, but it is very helpful and will get easier along the way. We do not want to use systematic reviews without critical appraisal, because our clinical practice is based on the results. Thank you for your attention. I hope this was helpful, and I wish you good luck with my translation rules.